You're listening to Health Innovators, a podcast and video show about the leaders, influencers, and early adopters who are shaping the future of healthcare. I'm your host, Dr. Roxie Mooney. Welcome back to the show, Health Innovators. On today's episode, I'm sitting down with Dr. Craig Joseph, who is the Chief Medical Officer at Nordic. Welcome to the show.
Thank you. It's a pleasure to be here.
It is so good to have you here. So today we are speaking with someone who has had many roles in the healthcare ecosystem that I think will be able to shed a lot of insights to our health innovators, as well as really being able to talk about some of the trends to be able to help transform the healthcare industry in maybe a faster way, right? Smarter, faster way. Dr. Joseph, if you don't mind, start off by telling our listeners a little bit about your background and why you do what you do.
Sure. It's a twisted, ugly story, but happy to share it. As an undergrad, I majored in computer science and then went to medical school. So, which was a little unusual back in the late '80s, early '90s. Became a pediatrician, practiced primary care pediatrics in the Detroit area for about 9 years, and was itching to look to do something a little bit more. I looked for somehow could I combine my clinical skill set with my technical background, and ended up getting hired for to work for an electronic health record company in Madison, Wisconsin called Epic. And this was back in 2005. Most hospitals were either on paper or using computers a little bit, but not really all in on an electronic health record. And so it was early times. It was fun.
Yeah.
Spent about 7 years at Epic, and since then have either been the chief medical information officer or working as the interim or full time CMIO at a number of institutions, running both Epics and their main competitor Cerner's electronic health record. For the last 3.5 years, been working at Nordic Consulting. We do general healthcare consulting, and focus a lot though on the technology.
Okay. And so tell us a little bit about your book that just came out.
Very excited. I co-wrote a book with a colleague about applying the principles of human-centered design to healthcare writ large. And so what we have found, and what I've found a lot working across the country, is that a lot of times people are trying to get folks to do something, either a doctor to write an order in a certain way, or a patient to follow the best practices or to take their medication on a regular basis. Yet the design around the workflows or the tools that we ask these folks to use seems to be lacking, and in a very basic way. And then we're shocked when we say, well, why is the doctor or nurse not doing what we want them to do? Why are the patients not following our directions? Don't they know it's going to help? And in fact, we've made it hard or difficult for them to do what is right. And so we're hoping to kind of turn that around at least a little bit by making some of the senior leaders at healthcare systems at least aware of the existence of human-centered design. Often they have specialists in design or human factors engineering at their hospitals, and those folks get overruled on a regular basis because that's not how the department chair of cardiology wants it to work.
Oh
That's
my
the
gosh. Preach,
Yeah,
preach, preach. This is one of
I
my
know.
boxes. Oh,
Yeah.
to that, I say we really don't have a technology problem or an innovation problem in healthcare. In many ways, I don't think we need more innovation. We really need a more adoption of the existing innovations that are out there. And the topic that you are bringing up and have written about is one of those strategies for us to be able to help change the direction of the adoption rate that happens with so many of these great innovations that just end up in the zombie graveyard because no one wants to use them for one reason or other.
Yeah, I couldn't agree with you more. If you look at most healthcare systems or hospitals, they have someone with the title of CIO. initially that was chief information officer. I've seen it become the chief innovation officer somewhere. Someone, this wasn't my line, but someone said they should really just be the chief imitation officer, right? Which is, hey,
Uh-oh.
we have these best practices out. We know what they are. There's science now. It's not just, well, I like that color or I think that font is best. We have science. We know how humans work, and just kind of copying, sometimes just basically copying what others have done, is the way to go. And I would love to see more of that. I'd love to see more chief imitation officers.
We want more of that. Okay, I've never
More.
heard that before. So human-centered design and design thinking, those ideas or strategies have been around for decades, and we've heard them be talked about and thrown around as kind of like one of the hot buzzwords in healthcare for a while now too. Why a book now on this topic? Where's the gaps?
Yeah. So certainly my co-author and I are not trying to um, do break any, new research grounds here. There are some basic principles. And what we're finding, as I kind of referenced before, is that leaders are sometimes saying, well, no, that's not how I think, or that's not how the department chair for
Yeah.
gastroenterology thinks, and they want it to look this way, whatever that is. Or they think that the patients would best respond to this sort of impetus, right? And that, so the goal of the book, and it's really written at a
Mm.
very high kind of 30,000 foot level, is
Yeah.
really for senior leaders and executives. And if I were able to give them any, one message, it would be, hey, you probably have these folks working for you. Maybe you should let them do what they do. And you should try to get out of their way and remove other obstacles that they have. So, in the book, we talk about things like getting rid of stupid stuff. That's actually the title of one of the chapters. That is not my term. That was a term of the title of a paper in the New England Journal of Medicine, literally called "Getting Rid of Stupid Stuff."
Uh-huh.
So some basic things, just to kind of keep your eyes on the prize, understanding how humans think, and then not trying to work against that, but in fact trying to harness that power so that makes it easy for you to do the right thing.
I talk a lot about hippos, and that hippos destroy great ideas, and that hippo stands for highest paid person's opinion. And how you describe some of those leaders, where they really are the hippo in the room, and it sometimes they don't even care what the data says. You've got folks in the room that have all the data to show that it's really not about personal preference, that here's data that says we will be successful and effective in this pathway. And often, highest paid person's opinion trumps what happens. And the project tanks, or it really just doesn't have as much success as it could. And that's really sad.
I am totally going to steal hippos.
Okay.
I love that terminology. I've never had a name for them, but that's absolutely correct.
Right.
And sometimes it's the highest paid person in the room, but sometimes it's a
Right.
well-meaning leader or
Yeah.
person. I'll give you a specific example. If you're when we're creating or configuring electronic health records, sometimes we have to make a list of things. And some folks will say, well, let's put the most commonly used item or items near the top so that folks don't have to kind of scan around or try to look for them. And that's great. But often you're wrong in terms of the data that those are the choices that you might make the most, but they're not the choices that everyone on that, all of the nurses on that floor are making,
Yeah.
or they don't realize that tool is actually used throughout the healthcare system. And so it might make complete sense for the floor that you're on, but did you realize the emergency department's also using that same tool, and that their choices might be very different than your choices? And so kind of making it in a more standard way, either alphabetical or some other way that makes sense so that people know, oh, if I'm looking for X, I know where I'm going to find that. It's going to be near the bottom. It's going to be near the top. It's always going to be in the same relative position.
So, in general, healthcare tends to be a laggard, right? For a number of best practices. So, is that what's happening? That it's been around for a while, and now the industry's finally ripe for paying attention to messages like this. Maybe they've experienced the pain of ignoring these principles and are ready to actually pay attention. Maybe their jobs are at stake, or certainly lots of dollars are at stake.
Yeah, certainly healthcare is a laggard in terms of adoption, and we understand why, right? It's a conservative
Mhm.
field. People can't tolerate mistakes and
Oh,
errors, right? Folks can be harmed or killed, and we
yeah.
all want to do everything in our power to avoid that.
Mhm.
The problem is that sometimes you go too far, and you take that pendulum and you push it all the way so that it's impossible to make change, even when the data show that change is needed. And so I think folks are kind of coming around to this concept. And what we try to do in the book is make it even more obvious, and try to use a lot of examples outside of healthcare so that we can then turn them inside, change your view. So, we talk about a door. Um, uh, Don Norman wrote a series of books about design and of everyday things, and
Mhm.
he talks about doors. And oftentimes, when you look at a door, you need a direction. It tells you to push or pull or how to handle the door. And in fact, if you need directions and instructions as to how to use a door, it's probably not a well-designed door. And once you have that kind of concept of,
Yep.
well, it looks good, but people are stuck, they're always pulling it when they're supposed to be pushing it. That means you didn't give the right affordances. You didn't create that door in the right way. And that's a problem with the door design. That's not a problem with the people that are trying to use the door. Right.
Right, right.
And these are the messages. I do think it's that leaders are are well positioned right now to kind of take that information and um, see the errors of their ways. And again, mostly no one tries to do the wrong thing when they're creating a workflow or creating a new tool or an app. They're trying to do the right thing, but it's difficult in medicine, like we can do in technology. We can do A/B testing and just say, well, we'll do it this way and this way and see which one has the better outcome. We don't generally do that in healthcare unless we're doing research. Generally, we know what we're trying to do and we want to do it the right way. It's just making it easy to do that thing, to stop putting obstacles in front of patients or clinicians' way. That's the goal, and I think that message will resonate now.
Yeah, that door is just such a great example. Maybe do you have a couple of other stories from the book, maybe to share with us, that kind of help set the tone for what are some of the principles that we need to make sure that we're implementing?
Yeah, absolutely. Yeah, one story that I talk about happened to me when I was first out in clinical practice. Again, I mentioned I'm a primary care pediatrician, and this was about 20 years ago. Had a patient a small child, and had asthma, and responded nicely the couple of times that he came in. We gave him some breathing treatments in the office. He responded well, and so we said, you know what, we're going to give you a machine, a nebulizer, to take home. And nowadays, those are pretty straightforward machines. But back in the day, you had to jump through all these hoops and get insurance permission. And we had to have someone come out and supply that nebulizer machine and show the mom or dad how to use the machine with the child. And then they had to go to the pharmacy and get the prescriptions. Well, anyway, the patient kept coming back, and the mom said, he's wheezing. I gave him treatments. It doesn't do anything. We would give him a treatment in the office, and he responded quickly. And the first one or two times that happened, I said, well, you must have done the hard work, and we just kind of put him over the top. But the third time, my medical assistant started asking the mom questions that I have to say that I wouldn't have asked.
Mhm.
And my medical assistant said to the mom, show me exactly what you do to give a treatment. And she said, well, sure, I take the medicine in the ampule, and I kind of just pour it into the the mask, the area in the mask where I'm supposed to put it, and I give them the treatment. And what she was telling us then is that she was giving normal saline, which is just saltwater treatments. She wasn't actually putting in the medication, the albuterol, um, that was supposed to be mixed in that with the normal saline or the salt water. So it's not shocking that the patient wasn't getting better. Now, how is that possible? whose fault was that? Well,
Right.
luckily it wasn't our fault. We sent the patient home, and someone had to go and explain to them how to use the machine. There was some miscommunication there, so probably all of us were to blame in one small part. Well, that doesn't follow the basic principles of design, because we're making errors available to happen. Right? It's possible for the patient or the mom or dad to mismanage the medication, either drawing up the wrong amount of the medication, or in this case, not including the medication at all. She
Mhm.
thought she thought the medicine came in the little pink ampule, but in fact that was just the normal saline. Now you can't actually buy those two things separated. Now it comes in an ampule that's pre-mixed with normal saline and with the albuterol.
Right.
Um, that makes that error impossible. And those are the kinds of things, thinking about how you thinking about how to kind of error proof your invention or your workflow or your technology, so that it's impossible to do the wrong thing, is great. And that's a little thing that was not a technology problem. That was just a lack of kind of thinking about the outcome, and taking something that we've used in the hospital, where we have skilled nurses who've been doing this for years and years, and then asking parents to take on that responsibility, a little bit difficult. Um, another story that we reference is actually a journal article from the fairly famous New England Journal of Medicine, and it was called Gross. That was
Hmm.
the title, Gross. But in fact, that was just an acronym for getting rid of stupid stuff.
Uh-huh.
Getting rid of stupid stuff. And you think, boy, how do you get into the New England Journal of Medicine with an article about getting rid of stupid stuff?
Yeah.
And the answer was that this was the chief medical information officer at a hospital, who said, we just asked people, we asked our clinicians, our nurses and our doctors and our front desk clerks, are there things that you do every day that you think are just dumb, that don't seem to add
Oh
any
my
benefit,
gosh.
right? It seems like a straightforward seems
Unleash
like a
the
straightforward
dragon.
question. Well, often though we see that does happen. Lots of people kind of ask these questions, but they don't get into the New England Journal, and the reason they
Right.
don't is that they usually don't follow up.
Hmm.
They don't follow up, so they either get that list and they fix a few things, but mostly they either don't fix things or they can't fix things. But their errors in the inability to communicate, like they don't respond. So it's a black box. I put in a suggestion, I called the help desk, and I never heard back. And I think that the key differentiator for at that hospital, at least, is like they responded to everyone, and they said, you know what, that is a mistake. Asking a nurse to document the smoking status of a 2-month old, probably not helpful. We'd like to know the smoking status of the parents, because that tells us about secondhand smoke, but we don't really care if the 2-month old is smoking, because we're pretty sure the 2-month old is not smoking. That was a requirement
Yeah.
that was configured into the electronic health record. How can we remove that? What other things are there that, hey, maybe it made sense to ask that question 5 years ago or 10 years ago when we were working in a different place? Questions. I don't know if you've heard of this thing called COVID. I don't know if you had that.
Yeah.
Um, yeah, where I live, we had this thing called COVID.
Right.
Well, we started asking people, for good reason, had they traveled outside the United States? Have they been around someone sick? Have they had a runny nose? Those questions are great when you're in the middle of a global pandemic. Today, they don't really make a lot of sense. And yet still,
Yeah.
I think many of us, I know I've
Imagine.
had the experience. Yeah, still someone's asking me if I've traveled outside the United States, when I'm just going to see my friendly doctor about something totally unrelated. So uh, those are the kinds of things, like, I think that's probably stupid. Maybe I'm being a little bit harsh, but
Yeah.
those kinds of things really make a difference with the way people interact with either that healthcare system or a particular piece of technology. I'll tell you, I as a physician and a physician leader, I've been on the negative side of some unhappy physicians telling me about
You
things that
think?
that that uh, that didn't make sense. And
Woo!
what's amazing to me,
Especially
and
in
I
the early 2000s or mid 2000s. Yeah.
Well, when I worked at Epic, that big electronic health record vendor, my children were young, and when I go on a business trip, they would often ask me, where I was going and what I was doing, and I said, "Daddy's going to get yelled at by doctors." Um,
Exactly.
and so sometimes it was appropriate and sometimes it was inappropriate.
Yeah.
What I found, and I think a lot of, I think I'll talk about physicians as if they're normal humans. Um, Oftentimes the best kind of reaction you get to getting rid of stupid stuff is are little tiny details, like little pebbles in your shoe. So there'll be a documentation template that they use that there's a typo, or
Mhm.
that there's two periods after the second sentence in the fourth paragraph. And since clinicians
Like,
are often kind of
sleep.
type A, they have to, every time they use that, they have to go in and fix it, and it makes them crazy. I
Right.
could fix that in a second, which I
Yeah.
will. I will
Mhm.
fix that in a second. And then they're like, "Oh, you're great. Like, this system is great." And I'll be like, "What about all the problems that we really have, where we don't have the functionality for you, or
Right.
it is quite awkward?" They're like, "Oh, no, no, that's okay. You fix the double periods." Um, these are these are
It's
just
not for
like
real.
this. Absolutely.
Mm.
And so it's the small things. It's that, getting rid of stupid. Again, is it really killing the nurse to ask to document on a 2-month old whether they're smoking? No. It's really a half a second, and they probably do that 5-6 times a day in a pediatric clinic. Not the end of the world, but it makes you think, like, this software is dumb. The people that make me use the software are dumb. This whole healthcare system doesn't seem to understand what they're doing. Right? It's these little things, and they build on each other. And I think that's one of the messages that we're trying to get across, which is, uh, sometimes it's the little things that make all the difference, and the big egregious killer problems that you're really trying to solve, and you still do need to solve, but you haven't solved yet, you get a buy from
Right.
your
Right.
audience.
Yeah. One of the things that comes to mind is, we're talking a lot about health systems here. Although human centered design and design thinking can be applied in any scenario or any situation, but those are organizations that have a lot of margin compression, a lot of in the red a lot, don't have a lot of resources to spend on things like this. I think, there's a lot of people that might think that human centered design is a nice to have instead of a must have. And so if I've got a certain amount of budget to work with, I might buy these solutions. I might not invest in human centered design consulting or strategies that might cost more and take a lot more time for us to be able to actually like execute. So what do you say to those kind of people? What's the calculated cost of not deploying something like human centered design?
Sure. Like, well, you can pay now, or you can pay later, right? That's really what it comes down to.
Yeah.
And I
Mhm.
would argue the cost is generally not significant. It's um we, again, talking about those Norman doors, that
Mhm.
Don Norman kind of pointed out. Um, this is not, once you understand and have like an appreciation for the fact that there are people that know about this kind of stuff, just incorporating that at the beginning of the project, whatever that project is. It might be designing a new hospital. It might be implementing, new technology, or creating an app. Once you kind of understand that those things are out there, they're pretty available, and it's a pretty low bar to get to. If you ignore it and say, "Well, I don't have time to even think about this," because generally you are thinking, you're trying to make a decision: do I make this red? Do I make this blue? Do I make this easy to do? Do I make it difficult to do? Those decisions are going to come your way, and you're going to take time to make them. Using the right evidence, kind of having that right background as you go in, is really the key. We know what happens if you completely ignore it, right? The hippo, you get the hippo problem of,
Yeah.
it works great for the chief of cardiology. I always blame the chief of cardiology. It's not fair to them, but I do it anyway.
Right.
This product or this workflow or this building works great for the chief of cardiology, but it can be pretty horrible for the other cardiologists. It can be pretty horrible for the patients. Doesn't work for them. And you're
Yeah.
going to have to either you have to go back and redesign, which costs money and time and resources, or you have to live with this kind of suboptimal outcome. And both of those choices are bad. So I would I would say like, hey, it doesn't take too much time or money to kind of try to do it right. You're not always going to get it right, of course, but you're going to be instead of getting it right 20% of the time, you're going to get it right 80% of the time. Just having a sense of what design thinking and human centered design entails.
Yeah, yeah, absolutely. So, are there any particular areas in healthcare where this, I mean, you threw out a couple of examples, but are there any particular stakeholder group or any specific area in healthcare where this is just really, there's just a huge gap and it's really drastically needed?
I certainly see it as a clinician. I see it on the clinical side.
Hmm.
And
Yeah.
so, certainly, the tools that clinicians, doctors, nurses, therapists are using every day can be better. Now, some would say they're horrible. I wouldn't go that far, but I would say they can be better. Um, that's certainly a focus of a lot of my time. But
Mm-hmm.
you also thinking about revenue cycle. Thinking about collecting, making it easy to do the right thing. That what that means is if I do a procedure that the hospital or I could bill for, documenting it in the right way is really important. If I'm going to send a bill to a patient, I think we've all, at least in the United States, we all have been on the receiving end of bills from people we've never seen or met before, right?
Mm-hmm. Mm-hmm.
If you had a test, a biopsy, that's going to go to a pathologist, and they're going to send me a bill. And I get an X-ray or a CT scan, I'm going to get a bill from the radiologist. I'm going to get a bill from the hospital. I'm going to get a bill from the doctors who were taking care of me. And that's very confusing. So having a kind of a single bill, just making it easy for me to track and see what's going on in one place as opposed to having to go to multiple places. So it's not just, even though I specifically focus in healthcare, it's not just from the doctor and the nurse's perspective. It's from the patient's perspective. It's not just about the advice that we want to give to patients, but how to schedule an appointment, how to pay for that appointment. Those kinds of things are really important.
What kind of role is AI playing in human centered design?
Um,
And
it's it. Yeah. Go ahead. Sorry.
I was going to say, and addressing some of these issues.
I think we're going to see it taking a bigger and bigger role. Uh, AI seems already some of these very basic LLMs. I say basic compared to probably what they're going to be in 2 or 3 years.
Right.
Um, uh, Chat GPT can do a really good job, and it's already being leveraged. That those kinds of LLMs and generative AI are already being leveraged today in healthcare systems. In fact, when you send a message to a patient from a patient to a physician asking for advice or what you're supposed to do next, there are some hospitals today where that is being pre-processed and a suggested response is being made by an LLM. Now, it's not going to you; it's actually going to your physician, so that the physician can look at what you've written and then see a sample response from the AI, and they can either take that or modify it or throw it away and
Yeah.
start from the beginning. But those kinds of things are going to be getting closer and closer. There was a pretty preliminary study where they looked at responses from physicians to questions that patients had online, and then looked at the way that, or then had the LLM respond to the very same questions, and then gave them to different patients, and said, which of these doctors, one of them was a doctor and one of them was a computer, which
Yep.
of these doctor, but you didn't know which of these doctors do you feel more positive about? Do you feel is more empathetic, right? And I think you've already guessed which one
Oh,
it was, right?
mm,
Um, the LLM, the AI,
yeah.
seemed more empathetic. Now,
Uh-huh.
there's lots of reasons we can talk about. You could say, well, the doctors don't have all day to generate these responses, and they're tired and doing this at home often after hours. And the computer is a computer, and it doesn't get tired, and it doesn't get overworked. That said, still, there seems to be some what seems like empathy from an AI. And if it's
Yeah.
got empathy, then it can kind of not feel, but act like it's feeling your emotions. And I think that a lot of the design things that we talk about that we see are going to be automatically incorporated, and the AI may not be able to tell us why, but it will come up with the best solution, the best response, the best workflow, the best architectural blueprint for, a waiting room or a hospital. And so I think it's positive and exciting.
Yeah, I mean, I've thought about that a lot to see if, sometimes some of the limitations when I'm doing work around co creation, which is in the same field as human centered design, there's always, the sample size, right? So we're involving humans in the process, but is it statistically significant to reflect an entire population? And then the cost of time associated with trying to have a large enough sample size for it to be statistically significant. And then the ability to use tools like AI that represents a bazillion points of view. And so you're able to get that scalability and input fast. And I think there's ways with the prompts to be able to make it really, really specific to those use case scenarios to get really good outcomes. Of course, there's what, if you don't have the right prompts, you won't get the right output. But I think we'll see, like, I agree with you. I think we'll see more and more of that. And that, I think, will help scale the adoption of human centered design faster.
Yep. Yeah.
Yeah.
No reason for me to guess how to configure that part of the technology. Can just ask the AI, and it's probably going to be right more often than I will, even with my fancy understanding of design thinking.
And much more effective, I think, than the hippo. I hate to say it.
I think flipping a coin might be more effective than those
Right.
hippos.
Right, right. Yeah. Well, is there anything else that you'd like to share with our audience as we wrap up here?
No, certainly if anyone wants to connect with me, LinkedIn's a great way of doing it. Just type in Craig Joseph, you should find me. Also, we wrote a book, and if you're interested, it's on Amazon. So check it out. Be happy to talk about that. I
What's
really
the
think
name of the book?
it's. I'm sorry.
What is the name of the book if people want to
Oh,
purchase?
designing for health, the
Okay.
human-centered approach. Designing for health, the human-centered
Awesome.
approach. I guess I should say the name of the book. Yeah.
We'll make
Um,
sure we include a link here.
awesome. Well, thank you. Yeah,
All right.
that's
Well,
that's
thanks for joining
that's
me
it.
today. Appreciate it.
Thank you. Thanks for having me. It was a great conversation.
And for those that haven't subscribed to the show yet, click below and subscribe, and I'll see you on the next episode. Thank you so much for listening. See you on the next episode of Health Innovators.